Basal cell carcinoma, BCC, an overview. Basal cell carcinoma, BCC, is the most common form of skin cancer and represents approximately 80% of all non-melanoma skin cancers. It arises from the basal cells, which are located in the lowest layer of the epidermis and is generally associated with cumulative ultraviolet UV radiation exposure. While BCC is typically slow-growing and rarely metastasizes, early diagnosis and treatment are critical to prevent local tissue destruction and disfigurement. 1. Epidemiology. BCC is most prevalent in fair-skinned individuals and is more common in older adults, though its incidence is increasing among younger populations due to sun exposure and tanning practices. Men historically have been more affected than women, but the gender gap is narrowing. Geographically, areas with high UV index, such as Australia, have the highest rates of BCC. 2. Risk factors. Key risk factors for BCC include UV radiation. Prolonged exposure to UV rays, especially during childhood, is a significant cause. Skin type. People with fair skin, light eyes, and a history of sunburn are at increased risk. Age. The risk increases with age due to cumulative sun exposure. Genetic predisposition. Conditions such as basal cell nevus syndrome, Gorlin syndrome, increase susceptibility. Immunosuppression. Patients undergoing organ transplantation or receiving immunosuppressive therapy are at higher risk. Radiation exposure. Previous therapeutic radiation can predispose individuals to BCC. 3. Clinical presentation. BCC typically develops on sun-exposed areas such as the face, neck, and arms. Common subtypes and their characteristics include: A. Nodular BCC. The most common subtype appears as a shiny, pearly nodule with visible blood vessels, telangiectasia. May ulcerate, leading to the classic rodent ulcer appearance. B. Superficial BCC often presents as a red, scaly patch with a slightly raised border, common on the trunk and shoulders. C. Morpheoform, sclerosing BCC, less common but more aggressive. Appears as a scar-like ill-defined lesion. Tends to infiltrate surrounding tissues. D. Pigmented BCC. Contains melanin, giving it a brown, blue, or black appearance. May be mistaken for melanoma. 4. Diagnosis. Diagnosis of BCC typically involves clinical examination, identification of characteristic lesions, dermatoscopy, a tool that enhances visualization of lesion structures, biopsy. A confirmatory biopsy is often performed to assess histological features. 5. Management. The treatment of BCC depends on factors like tumor size, location, and subtype. Surgical excision, the standard treatment, ensuring clear margins. Mohs micrographic surgery, preferred for high-risk or facial lesions due to tissue-sparing benefits. Curettage and electrodesiccation, used for superficial or nodular BCCs on non-critical areas. Topical treatments. Imiquimod or 5-fluorouracil for superficial BCCs. Radiation therapy, reserved for inoperable cases or patients unsuitable for surgery. Targeted therapy. Hedgehog pathway inhibitors, e.g. vismodegib for advanced or metastatic BCC. 6. Prognosis. BCC has an excellent prognosis when detected and treated early. However, it can cause significant morbidity if neglected, as it can invade deeper structures, including bones and nerves. Recurrence is possible, particularly in high-risk cases. Prevention. Preventative measures include regular use of sunscreen with broad-spectrum protection, wearing protective clothing, and avoiding peak sun hours. Routine skin checks, especially for individuals with a history of skin cancer. 8. Conclusion. Basal cell carcinoma, while rarely life-threatening, is a significant public health concern due to its high prevalence. Public awareness about UV protection and early detection is critical for reducing the burden of this disease.